Good morning, good afternoon, and good evening. We'd like to welcome you to this webinar on new primary health partnership models jointly organized by the Private Sector and Health Thematic Working Group and the Gates Exemplars in Global Health Program as part of our ongoing mutual learning series on redesigning mixed health systems during COVID-19 and beyond. In this webinar, we will explore promising working practices in primary healthcare along with the role and contribution of non-state actors in primary healthcare partnerships in three country contexts: Singapore, South Africa, and the United States. Before we begin, a few quick housekeeping rules. Today's webinar is in the format of a 90-minute roundtable discussion. The webinar is being recorded and will be available via the initiative website, and as well as social media. We will email the recording link to audience members a few days after the webinar. We would like to invite you, our audience, to ask questions during the webinar through the Zoom Q&A function, which is now open and available. And in addition to typing your own questions, you can also upvote questions that other audience members propose using the thumbs up button on your Q&A panel. As well as being able to type your own questions, you can upvote these questions that other audience members ask that you feel kind of segues in what you would like to ask our panelists as well. Towards the end of the session, we will draw on these questions to ask one or two, to field a couple at our panel, and we will conclude our webinar with audience-related questions. Next, Vinay. So to introduce myself, I'm Priya Balasubramaniam from the Public Health Foundation of India, who will be co-moderating this session with my colleague, Dr. Desta Lekyo, who's the Global Director of Partnerships of AMREF Health Africa. And joining us as well from the Gates Exemplars program is Meredith Kimball, who is the Health Systems Lead. So welcome again, everybody. It is now my great pleasure to introduce the speakers of today's session. We begin with Dr. Yi-Jian Liu, the Chief Executive Officer of the National University Polyclinics in Singapore. He's a practicing family physician. Dr. Liu oversees operations, clinical quality, and patient safety matters of the polyclinics. He enables interprofessional and comprehensive care of patients, as well as communicates with regional hospitals in the integration and care of patients. He is responsible for the overall coordination of the emergency preparedness of polyclinics in civil as well as national emergencies, including pandemic situations. Welcome, Dr. Liu. Following him, we have Mr. Dan Gwinnell, the Project Director for Technical Advising with Partners in Health, the United States Public Health Unit. He supervises PIH's growing portfolio of work on COVID-19 in various states, counties, and cities in the United States. Dan spent 6 years working with the Clinton Access Initiative in various countries across sub-Saharan Africa, and most recently, as well as country director of the Sierra Leone office. A very warm welcome to you, Dan. We then have Mr. Gustav Prakelt, who is the founder and chairman of the South Africa-based Prakelt Group. He's a leader in the use of open source mobile technologies to deliver essential information and inclusive services to thousands of people around the world. In 2003, he founded Prakelt Consulting, a for-profit agency to help clients deliver content and information to any handset across the African continent. Prakelt Consulting has been responsible for many seminal launches in the African digital arena, including the launch of mobile television and the first use of social impact Please Call Me technology. Welcome, Gustav, to this webinar, and we really look forward to having you. And last, but definitely not the least, we have with us Dr. Yi Wai Lim, who is a physician researcher and associate professor at the Yong Lu Lin School of Medicine, National University of Singapore. His two key areas of interest is the design and evaluation of integrated care system and the role of social innovations in health. His work has involved healthcare systems in Southeast Asia, the Middle East, Australia, and the US, covering areas including pandemic preparedness programs, primary care capacity building, as well as elder care and healthcare technology assessment. So a very, very warm welcome to you all. And before I hand over this moderated panel session to my colleague Desta, I'd like to tell you a few words about our mutual learning series and what it is all about. So the mutual learning series really came about when a group of us health systems researchers from Health Systems Global, from the global north and south, got together from various institutions to focus on better understanding the role and diversity of the private sector in health. We were especially interested in how and what kind of evidence is needed to better engage both the private sector and governments in partnering on interventions for strengthening health systems for universal health coverage. So the mutual learning workshops were really a short series of digital roundtables that really explored how governments and the private sector collaborated in response to COVID-19. And from this collaboration, what kind of lessons were evolving, what were some of the mechanisms of engagement that could be applied to redesign and rebuild health systems capacity for universal health coverage. So the objective of this platform was to generate fresh ideas on how private health sector delivery and access can engage researchers to partner more effectively with governments, as well as public health mechanisms. And the outcome of this series of engagements that ranged from partnership models to governance to a series on with the Global Parliamentary Alliance and the role of evidence was really the creation of this mutual learning platform, which is a collaborative platform for value creation through both evidence and opportunity between non-state actors and governments to identify health priorities to strengthen country health systems. Our platform engages in convening a range of stakeholders to matchmake partnerships for change, research networks to work with private as well as public sectors to pursue new research directions, and to enable and support intervention-based partnerships at national and regional levels. So that's it with the mutual learning series, and I hope you enjoy the discussions and the presentations to come. I'd like to hand over to you, Desta. Over to you.
Thank you so much, Priya. It's great to be here. We have a phenomenal panel and much to learn. I'm particularly intrigued by the whole Singapore health system. I think it's a very unique health system, and I think we have lots to learn from it. And of course, our partners at PIH, really good to have you on board, and Gustav, you as well. We will start our discussion today with a presentation from Dr. Yi-Jian Liu from Polyclinics in Singapore, and just move along down the line as we move forward. So Dr. Liu, please share with us your presentation, and looking forward to it. And if you can just put this on slide share, that would be great. Thank you.
Are you able to see the slides? Just put it up.
Yes, we can see the slide. Yes, please go ahead.
Thank you very much. Thank you, the organizers, for allowing me to share my little experience in the polyclinics. That's for the public sector healthcare system in Singapore. So I will divide my talk into three short portions. The first one on the overall finance system for the public sector population. The second is the response plan in the COVID situation, relationship between the public as well as the private general practitioners in Singapore. And lastly, the ongoing relationship that the public sector and the private sector primary care has been going on even before COVID in terms of the care of patients in the community. So I just run quickly to this overview. I think you will know that Singapore is a small island with a packed population of 5.7 million. And we're thankful that through the years of development in the industry, economics, healthcare, education, finances, we are able to reach a reasonable life expectancy at birth, and also as well as the prolonged life expectancy at birth. And we have this interesting healthcare philosophy that we want to have a multi-payer scheme from the government as well as from the provider, plus the patients themselves to co-pay in this. So this is what we call this 1S and 3M, which I will elaborate more in this diagram. So you can see that from the government, they have come up with subsidies, and they will also be providing various schemes and assistance through means testing to patients with financial issues. They will go through the means testing, and they will decide how much further funding they can get besides the subsidy that the government is giving to the general population. And they will also come up with some special schemes for the pioneer generation, namely people who are born before 1965. That was the year of our independence. And then later on, MG, Merdeka generation, where for people that are born in the 1950s, to allow them to have further subsidies and subvention in their care. And following that, they will continue to have other kinds of fundings through the primary care network funding, which I'll explain later on. Then for the provider in the public sector hospitals, as well as in the polyclinics, we will have the 3 M's that you can see here: MediSave, MediShield, as well as MediFund. These are national insurance programs that has been started in the 1980s. Initially mainly for the inpatients to ensure that they have adequate care in the hospitals. But later on, when they recognize that the population is getting older with more chronic illnesses, they extended the insurance plan to the patients in the community seeking care for chronic illnesses, so that the care can be now transferred to the community rather than to be stuck at the hospitals. And the private sector GPs can also get the patients to use part of the MediSave and part of the MediShield Life to pay for some of their illnesses, care for illnesses in the community. CareShield Life comes recently as a form of disability insurance especially for the elderly, so that when they turn up to have disabled situations in stroke or even dementia or other debilitating illnesses, they can have this CareShield Life. And then for the patients, there's also a point that they have co-pay, and if for the patient's care community setting. Thus far, described mainly for the patients in the public sector, but they recognize that, and the next slide also show a unique situation whereby how the care of the patients are divided between the public and the private sector for the primary and secondary care. So you can see that for the hospitals, majority of the care are rendered by the public sector hospitals. So they will get high subsidy and subvention, as well as assistance that I mentioned just now in the previous slide. When it comes to the primary care, where patients may be seen, may be seeking help for common illnesses like cough, cold, giddiness, headache, or they may have chronic illnesses like diabetes, high blood pressure, or lipid disorders. Majority are actually handled by the private GPs. And right now, we have about 20 polyclinics that are found in whole of Singapore. Usually, the government will plan to set up a polyclinic if the population in the area rises to, say, 200 to 300,000 head count. But they recognize that they would want to continue to have this ratio so that they will not have so many public sector polyclinics to provide huge subvention and subsidy for the patients. So they also pass on some of these assistance to the private GP so that they can also help in looking to look after these patients with chronic illnesses. This I will elaborate later on. When it comes to the COVID situation, we are thankful that we have previously past experiences in SARS, H1N1 that allow us to recognize that we need to have very close relationship between the public sector and the private sector. Back then, when we had SARS, the private GPs were very upset that they are not getting the PPEs that are needed to look after the patients with high fever and suspected SARS. Several of them have to close the clinics, and they were making and complaints were made even through the social media as well as the news to the government. So since then, they have decided that to come up with this scheme whereby the GPs can join in this primary healthcare preparedness clinic, whereby they will demonstrate that their clinic, whether is it 1 or 2 doctor setting or 3 or 4 doctor setting, fulfill the requirement of preparedness to have isolated areas for our patients with suspected illness, separated from another sector of the clinic where they can attend to patients they are not to have infectious disease. When they fulfill the criteria as well as demonstrating they are able to do the infection control measures, they are actually provided the supplies of the PPEs, and this worked well during this COVID period, whereby they are activated to allow the GPs to participate in managing the patients with suspected COVID conditions. And many of them are also involved in the nasal swab of the patients, so that they will not strain the public sector hospitals or polyclinics just for the tests. So this PHPC worked very well for us in Singapore. And I also extracted this article from BMJ describing the healthcare resilience in managing COVID situation in Singapore. And these are some lessons that we learned, that we need to have transparency and consistency in the information from the government down to the ground. They have actually come up with, for all these years, they come up with the SMS system, emails, even hard copy mails sent to the respective GPs, whether they are the private or the public sector GPs, to update them of the latest information, so that they will not be misled by some social media that may not be reliable. And the legal framework is allow us to differentiate the types of patients that need to be looked after by different people, by different providers, so that there is a clear communication track who these patients with suspected COVID can be referred to, right? And as well as others that may need to stay at home for 5 to 7 days while waiting for the swab test result, as well as for the symptoms to progress or to subside. And the vigorous testing comes in, as well as contact tracing, allow us to coordinate and cooperate very nicely between the public and private sector, so that there will be trust in the two areas. And likewise, you may have heard about our situation of the dense populations with the migrant workers, where there are high incidence of the COVID conditions. The GPs are also rendering their support to look after these patients in these dormitories. And the government is providing special funds to allow them to set up the clinics there to look after them, so that these patients need not go to hospitals unless really fulfilling the clinical criteria. Next, I talk about the relationship between the public and the private sector GPs, even before the COVID situations, where I explained to you, our population is getting older and more chronic conditions surfacing. the government recognized that it's not possible to build up more polyclinics for the public subvention and funding to support these care in the community. So they enroll the GPs to join in this primary care network, whereby the GP clinics band together to share resources in the administration of the laboratory tests, as well as claims to the various schemes that you can see on the right hand side, the CHARS, the NG, PG. And then at the same time, they still have their own autonomy to look after their patients. Then from the clinical data as well as some of these CHARS data, they are able to, the network administrators are able to show how the individual clinics are performing in managing their patients with the chronic illnesses that we see in Singapore: diabetes, high blood pressure, lipid disorders, as well as some of the cardiovascular complications. This allows the GPs to value add in their care, and at the same time can leverage on the various schemes and financial support to help the patients for the management. The patients, on the other hand, they are also assured that the care given by the GPs are as of the same standard as that in the public sector polyclinics. And as a result, because of the special funding from the government, the care rendered in the GP clinic is as affordable as what they can experience in the polyclinic. So there's a strong relationship that is building up in these years, even before the COVID situation has arisen. However, what I painted may sound very rosy. There are still many things that we are not able to gel together because of the funding issues. Like, for example, although there are funds rendered for the care of patients in the community, there are still, the funds is never enough. The GPs are only able to look after the patients with, say, 1 or 2 chronic conditions with maybe up to 5 medications. But if it's beyond 5 medications, the patients will naturally go to the public sector polyclinics or hospitals for care, or that's where the care is more affordable. So there's still a lot of things that we have to juggle with, but this is what we aspire in our cluster in NUHS, where we want to have a family physician for every Singaporean. Even if it's not one person, it can be a team of family physicians looking after them, and then the care can be rendered between the family physician and the specialist, and we can also have a close relationship between the public and private sector in that links with the medical as well as the social issue. And then we aspire to have 1 EMR in every patient. Again, this is a tough call for us in Singapore because the IT system that is found in the public sector is far too expensive for the GPs to pay for it, and there's no currently there's no clear incentive to allow everyone to have the same EMR system. But still, we want to aspire for the things that we are going for in terms of going beyond hospital to community, so that the cost rendered in the hospital is only meant for those with high risk rather than everyone, and then that the value comes in not just with the good care, but also with affordable price. And definitely when it comes to the care of the patients, it will not just be for people with illness, but also preventive medicine, so that they will not get any of these high risk problems as well as complications. Yeah, so that's all I have. Thank you very much.
Thank you so much, Dr. Liu. I always find the Singapore healthcare system very interesting, and I think you've given us a very good perspective of what you're doing there, and it's been very informative, rewarding, interesting, etc. I would like to ask Dan Gwinnell to actually now share with us a very different model of healthcare, and certainly model of partnerships. Dan will talk to us about the US experience and is with Partners in Health. So Dan, can I hand it over to you, and maybe you just share your screen as well?
Absolutely. I just am trying to find the window. Here we go. All right, can everybody see that?
Yes.
Great.
If you can put it on slide view. Yes, excellent. Thank you.
Okay. All right, perfect. Thank you so much for having me here today. I'm going to talk a little bit more about the social sector than the private sector because I work for an NGO called Partners in Health. I'm the project director for technical advising for our US COVID response. PIH is a global NGO that works around the world on issues of community health and on primary care. We've also done a lot of work on outbreak response from MDR in Kazakhstan and Russia to Ebola in Liberia and Sierra Leone. And now we work on COVID in the US. The response to COVID in the US is quite a bit different than the response in Singapore. It is a global disgrace, and we have been completely unable to mount an effective and equitable health response. Yesterday was, I believe, 1 year from the day from the first confirmed case in Wuhan, and it was also the day that we passed 250,000 deaths in the US, which is a very grim milestone. And it's quite easy to sort of blame the criminal neglect of the Trump administration, and that's certainly a part of it. But also for years, we've functioned in the US without anything resembling a true health system. Our pyramid is inverted from what Dr. Liu showed. Most primary care, especially for low-income individuals, happens in hospital emergency rooms. And so it's no wonder that we were caught off guard by this and that it's spun out of control in the way that it has. But of course, we didn't expect it. So I think that we fundamentally just don't understand what health and primary care is in the US and how it can help safeguard against pandemics. This is a chart from the last Global Health Security Index that suggests that out of any country in the world, the US is #1 in pandemic preparedness by quite a wide margin. And this is the case, I think, because we tick the boxes, we have plans, we have epidemiologists, but we are this sort of health system that really fundamentally devalues primary care and community care. And so that gets you to something like what we saw in New York, where nobody knew until the last moment that the city shut down in March and the whole world was watching that something was really genuinely wrong that would change everybody's lives for the foreseeable future. The other thing I just want to highlight is that what this gets you is untenable outcomes. 250,000 people dead and people of color are bearing the brunt, as they always do in the US, with much greater mortality rates. You are 4 times more likely to die than a white person if you are a Black person with COVID. And this might be a little bit too philosophical for this presentation, but I was reflecting yesterday as we passed the 250,000 mark, that there is, such a thing as a good death. There isn't an easy passing surrounded by friends and family. And this chart is an aggregation of individuals who have been denied that, who have been neglected or punished by the state for their whole lives and died alone, gasping for breath in some hospital hallway. And that, to me, is the US health system in a nutshell. But there is some hope. So that's the context. There's no sort of health system to speak of, no understanding of sort of social pathology and medical pathology and how those two things intersect and sort of a regressive political and policy environment. But when you get below the federal level, when you get down to the state and county and city level, you can find jurisdictions that have extremely strong leadership that really want to prioritize primary care and social supports. And so our journey on COVID began when we were invited by the state of Massachusetts to serve as a partner to the Massachusetts Department of Public Health and set up their contact tracing program. So we started in April by hiring a really large cadre of contact tracers to manage that program, which has become sort of the gold standard for contact tracing and case investigation in the US as we move along this sort of cascade that I've showed here. That turned into something much broader. So after we started working in Massachusetts, we received a deluge of requests from other jurisdictions with strong leadership saying, how can you help? And so we started the US Public Health Accompaniment Unit, which is a little bit of a mouthful, but that's what we're calling it, and began working in 10 jurisdictions around the US. And the model here is simple. Governments can have strong leadership, but also still be undercapacitated. And sometimes deploying a handful of people to provide technically strong shoulder-to-shoulder support can make a really transformative difference. And that's what we do in the public health unit. And these are some of the services that we offer, both in terms of the response cascade, the kinds of enablers that give you a good COVID response, and then some really sort of services for key populations and how you deal with COVID in undocumented communities, unhoused communities, and so on and so forth. Where do we work? 10 places in the US, as I mentioned. I spent the first 6 months of this project embedded in the Newark Department of Health, which is a really tough city, but it shows you what you can achieve. The Newark Department of Health is understaffed and under-resourced, but they have this sort of true health equity agenda, and they just needed a little help on the technical side and the coordination of the response, because why would the Newark Department of Health be able to sort through a PCR and rapid antigen testing strategy for COVID, or set up contact tracing software, or figure out how to establish a program to provide social supports in the absence of leadership sort of further up the chain? And so that's what we're here for. That's the model, with a team of 30 spread across the country, working in the sites that you see highlighted here on the map. The challenges are many. Obviously, there's sort of opaque or non-existent decisions from the federal government. There's funding shortages, but Newark is now doing 1,000 tests per day. They have around 30 full-time disease investigators and contact tracers. They've prioritized community engagement and made sure that people are getting the social supports that they need to safely isolate and quarantine. So it has, to a certain degree, been a success. What does the future look like? I wish I could say this is the state of all of our sort of key partners. On the one hand, I think that the future is promising, because we will get a highly efficacious vaccine that will provide long-lasting immunity. And then on the other hand, I think another 250,000 people will die before we get there, based on the curves that we're seeing in all of these places. And we're going to have to put major restrictions on public life. And when you see a place like Ohio that is now at 400% of its previous peak, I don't know what the future will hold for some of the places that we're working with. One of the questions was about sustainability of all of this. And I just want to be clear, we are trying to ensure that the technical expertise that we build helps prepare the system for future preparedness. We're doing some advocacy work in a serious way at the federal level, which we hope is influential under the Biden administration and helps move things in a more sustainable direction. But for now, we're just focused on the present, and when we're not thinking about sustainability in that same way. And that's sort of okay with us. Sustainability, we talk about this in PIH a lot, it's so often used as a weapon against the poor. You can't sustain it, so you shouldn't do it. I've been hearing that for my entire career. PIH has heard it for the last 30 years of its existence. Can't treat poor people with MDR-TB. They won't take their medicines. It's too expensive. Focus on prevention. We heard the same thing for HIV. Too expensive, not possible. 25 million people are on HIV treatment, and nobody would have said that was possible 20 or 30 years ago. And we can save people with COVID too. Somebody in a 7-person family who lives in a low-income household and tests positive, get them a hotel for 2 weeks and make sure food is delivered to their door every day. And we hear these protests, and even now, oh, it's not sustainable. But I first of all, why not? You can do it, and not doing it is unimaginable. And I think that the other thing we have to recognize is that when these things occur, when that person does get that hotel room, and that person does get that food delivered to their door, that may not change the overall arc of COVID in the US, but that does change that individual's life and protects their family as well. So that's my brief comment on sustainability. I don't know what the future will bring. I do hope that this all means something in the end, and that we use it to make change in the way that we think about public health in the US. And I will stop there. Thank you, everybody.
Thank you so much, Dan. Yes, the US situation is quite distressing, and I'm glad to see that you have this model or intervention that you're using, and that it's working. In fact, I think we need more of this in the US than anywhere else. I would like to actually now just turn towards Gustav Prakelt. Gustav, you've done some interesting things in South Africa, and maybe you can talk about, on the technology and digital side, what you've been doing in South Africa, and just share with us a little bit on that. Do you have any slides to put up? If you can put up your slides.
Can you quickly do that? I'll just share slide showing.
Yes.
Great.
We can see it.
Fantastic. I just want to start by actually just saying it's a real privilege to share some of the work that we've been doing. And obviously this is only possible because of the tremendous work the Department of Health in South Africa has been doing. Actually, just want to call out, or just so impressed with the work that Dan's team has been doing in the US, and obviously the tireless work that all the health workers are doing in really trying circumstances. Obviously, I think one of the interesting things about South Africa, and what I'll briefly talk about, is it's so interesting to see how the different countries have responded during COVID. Obviously, a unique set of circumstances in every country. The South Africa response was almost the opposite to the US one, in the sense that we had an extremely hard lockdown almost immediately. I think one of the interesting things is the effects I think we were spared the worst impact in South Africa. We haven't really had a second wave yet, although that might still be coming. But I think what I want to talk a little bit about today is just how the South African government dealt with the issue of communicating around the lockdown, around the COVID-19 response, and especially the role of digital. South Africa, we're in an interesting situation that it's a highly unequal country. We have many people in poverty, very high levels of inequality, but really, really high penetration of mobile devices, almost universal access to mobile devices. And so digital presents itself as a really good opportunity or good channel to communicate with end users. And I think what we realized in COVID-19, it's kind of become a forcing function. There are many countries that already were doing lots of digital communication or universal communication, but certainly that was not the case in South Africa. And so when lockdown happened, we've been working in South Africa for the last 10 years with the Department of Health, primarily in maternal health and deeply integrated into the primary healthcare system. But we've been depending very much on the primary healthcare system, enrolling patients and obviously providing primary care. And the interesting thing is, as COVID-19 happened in South Africa, is how could we support the government, and how could we get fast, accurate information to our citizens? And we've all seen the rise of fake news, of myths, of all sorts of information that we don't want in the market. And the question was, how could we leverage the work that we've done already through Mom Connect, where we were already communicating to 1 million mothers over messaging and over WhatsApp? Could we do something to roll out a platform to communicate with our population at rapid scale? And that's really what we rolled out and what we launched in South Africa. So we launched on the 20th of March, and the core principle really was, how do we communicate with everyone in South Africa to provide as universal a system as possible, to make news, information freely available, and to support our health system as they responded. And obviously, as health clinics were not available anymore, and we went into a hard lockdown. Very practically, we were launching this out over messaging, specifically over WhatsApp, which is pretty much universally available now in South Africa. It was available, very importantly, in all the 11 official languages. We made it available in 5 of those languages. The other interesting thing is we had a very high frequency of updates in terms of current case numbers. There were a lot of changes during lockdown in terms of what you could and couldn't do, and this became the primary mechanism. At one point, I think we were the platform that had the most traffic of any digital channel of anywhere in South Africa. News is updated on a frequent basis. The president actually spoke to the citizens on a regular basis and had TV addresses. But all missives and all information from the president were produced on this platform as well. And that really made it possible for us to maintain a single source of authentic, and secure information for anybody in the country. And so the results were pretty astounding for within a couple of days. Actually, we had millions of users. And for us, the real interesting thing is that we've maintained this traffic now for the last 6 months, going into almost 7 months that the platform has been up and running. Over 20% of adult South Africans have accessed it. Over 8 million active users on the platform, almost 500 million messages exchanged with citizens of South Africa. So actually, by far, the most used public health system in South Africa ever, and I think also actually the most active just general government platform in South Africa. So some of the things that were really interesting, I thought would be useful to share here, is things like, for instance, the fact that our Minister of Health, Minister Mkhize, personally tweeted. He's actually quite active, and he was personally tweeting around providing information. We had, you can see that actually one of the tweets on the screen, very, very frequent mentions on news. And you could see here what's really started to happen is very high usage. You could see at peak, we were doing almost 500,000 daily active users on the platform, which is during lockdown, when there really wasn't any other way to get interactive information, personalized information out to our citizens. So the other really interesting thing is this is actually a live dashboard that I pulled today just to share with the audience here. And you could see even today, we are seeing over 30,000 active daily users, and you can see what high percentage of returning users we still have. So it's still the primary means through which we can deliver content. And so in a way, what we think is what's happened here is that through this COVID line, we've been able to essentially launch a universal system now that people go to for any information that they would like to find. And you can see really interesting behaviors. I'm sharing with you here also just some of the data that we saw in terms of daily usage. And it looks like it's almost become like a daily check-in for a lot of people. And over time, we've been able to leverage the platform together with the Department of Health to launch other services as well. So just in brief, some things that I think were really interesting and then I think important to have learned is the fact that everything was developed in multiple languages, extremely high frequency in content updates. It was the one place where you knew that you'd find the correct information around where to get tested, what the current status was around PPE, mask wearing. All that information was continuously updated. It was fully integrated into all the touch points that the government spoke on, so radio, television, at testing stations. Literally every single time any ad showed on television, there would be a call to action to either go to the website or to this information line. We saw one of the really interesting effects was the National Help Center line, which at some point was getting millions of calls. In the automated reply, we actually started publishing this number as well, so that people knew that they'd have a way that they could message it. Another key learning is to, although it was a partnership, it was really owned by the Department of Health. The minister embraced it, the president embraced it. The number was promoted by key personnel, and I think the last point really is in times of crisis like these, you have to iterate. So the systems were updated continuously, and a lot of the features were actually launched after the initial launch in March. So maybe just to end, there was a brief overview of some of the things that we were able to do fairly rapidly because the Ministry of Health was open and experimenting here. So a couple of things that's happening now. Complementary services, I think very importantly, supporting our health workers is extremely important throughout this period as we came out of lockdown. Obviously, there's a tremendous strain on our systems. The other thing is that in South Africa, especially our economy has been really hard hit with a reduction of 7% of GDP. So we're looking at secondary effects of COVID, especially economic effects, and supporting our citizens through support programs around that. Obviously, the vaccine rollout that we're all aware of, and how that's going to be informed to our population. I think that the other really interesting thing that we're starting to experiment with now is a form of triage. As our health system is strained at the moment, one of the things that we're looking at is to provide triage services via these messaging platforms, so that we can effectively monitor the demand on primary healthcare and provide a backup support system. So what we were doing already with Mom Connect, potentially rolling that out in the HIV support program as well. So I think as a final point here, just want to just mention that this wouldn't have been possible without the Department of Health really embracing and understanding and thinking about the fact that we had to use digital. And I think it points towards, we've now been experimenting with WHO around a number of other programs, especially on mental health. And we think it's potentially a long-term sustainable platform. I like what Dan said around the idea of sustainability. If we can build a universal health communication platform, we think this is a necessary precursor and an essential component of universal healthcare. And I think it'll be an essential component, especially to provide universal healthcare at an affordable and sustainable level in the long run. So thank you for the opportunity to share some of the work that we've been able to do in South Africa.
Gustav, thank you so much. I know that COVID communication is something that everyone is at, and it's amazing that you've made some progress there. I'd like to actually invite now Dr. Yiwei Lim to join us. Dr. Lim, maybe you can just briefly share some slides with us, and then provide sort of an overview on what the takeaways are from our speakers earlier before you. So I welcome you and thank you for being here. And I know you'll discuss a little bit about policy practice, the role of leadership, etc. So very happy to have you, Dr. Yi. Please share your slides with us.
Thank you. I don't have any slides. I was busy taking lots of notes though, as the speakers were sharing their stories and their efforts in the COVID fight of COVID. And thanks very much to the organizers for inviting me to participate in this webinar. First of all, it's fantastic to hear such great and rich stories from 3 countries, Singapore, United States, and South Africa. Especially in the case of the United States, where the situation, as Dan pointed out, it's pretty grim with 250,000 deaths just yesterday. Because the presentations have all been really, really rich, I am going to focus on 1 or 2 points and allow maybe more time for dialogue and conversation with the audience as well. I'll start backwards with Gustav's presentation. I think it highlights the importance of partnership, where it's not just about providing service, but it's about infrastructure building. And so even though the partnership is between the government and a non-government entity that the Gustav organization represent, it really recognizes that it's not about immediately just providing a service to on social media, providing real-time information. It's also recognize the importance of infrastructure building with the digital platform, which after the COVID is over, the government and the country will benefit a lot, not just in terms of infectious disease pandemic, but any sort of information sharing that's required with the public in the most expedient manner. I think Gustav's story reminds me of how digital technology firms are trying to pivot to adapt to what is needed in the COVID situation. To give an example, Bodhi Health, which is based in India, was a social enterprise that started an online platform for training nurses and doctors in remote areas of India. But as COVID descended, upon all of us, they realized that there was a need for them to now teach healthcare workers how to use PPE, how to use mobile devices, even areas such as ventilator maintenance. So the governments have started to pick up and realize that digital technology, digital platform technology companies are pivoting and trying to take advantage of their existing expertise to help with the COVID situation. In the case of Dan's presentation and the work that he has done with PIH, I would highlight one point. I think one of the slides indicated the 3 columns where there was immediate services that were provided in terms of testing and direct healthcare. Then there were enablers, as Dan calls it, which is about maybe evaluation, epidemiologic analysis, and other sort of workforce development. And then finally, the social, economic, or the environmental factors. And I think for any sort of sustainable partnership between healthcare organization and non-governmental organization, it is important to think about not just the short-term service development and service delivery, but also the enablers and the long-term situation. And it's very poignant for Dan to highlight, how we think of COVID as patients needing testing and needing medication. But when you are in a lockdown situation, they need food, they need shelter. And we often forget about the social problems around people not being able to work. So for example, I recently, as part of this hospital at home program, which is a partnership between an academic hospital and a private GP group to provide inpatient care at home. So it's another type of partnership. And when we visited a single mom with 5 children, and she was having a cellulitis infection of the foot, and we gave her the opportunity to receive inpatient care at home. And once we entered her home apartment, we realized there was clearly lots of issues that had to be addressed, right? Including access to food and other support services. And so partnership during the COVID in terms of primary care or healthcare system in general is not just addressing immediate health needs or even healthcare for specifically related to COVID, but there are the externalities, what I call negative externalities, that have to be addressed as well. Turning to Ejan's presentation, I would say that Singapore, in a way, was quite fortunate because Singapore being a small country, it was easier for the healthcare system, including the primary care system, to respond to COVID quite quickly. Even then, I remember there was quite a bit of uncertainties at the very beginning in February and March, like should people wear masks? Are masks scarce and therefore we should not use them because healthcare workers need to use them. But what the situation in the past 6 months have pointed out is the strength that the government has placed on the primary care, working closely with the GP sector, which is set up a few years ago, for example, the primary care network. I think these relationships cannot be taken for granted. GPs are often practicing in single office practice, and they do feel isolated. And I think that it's very important in this case for not just the Ministry of Health, but Polyclinic to reach out to their private sector colleagues, not just providing support and services, but also a sense that we belong to each other. We are all part of a community. And I hope that the COVID situation, and it would be great to hear whether Ejan has sense, whether there's a greater sense of togetherness among the private sector GPs and the Polyclinic in response to COVID-19. Finally, one last point. I would say that when we think about primary care and new forms of partnership, it's helpful to not just think about a dual partnership where it's just private GP with primary care in the government sector, digital or technology firm working with the ministry, not-for-profit or NGO working with the government. It's also helpful to think of multi-stakeholder partnership. The role of philanthropy, the role of multinationals. How can they work with primary care providers? How can philanthropy play a role apart from just writing a check and in purchasing more PPE? What can they do more strategically, both in the short term and also in preparation for the next pandemic that would probably come more immediate, more quickly than we expected. So I'll leave with those points for everyone to think about, and I'll turn it back to you, Lester.
Thank you so much, Dr. Wei. And you know, what an excellent synthesization of the presentations that we've heard so far. I'm going to ask the speakers to please turn on their videos so that we can move into a Q&A and more discussion of some of the elements and important things that we heard earlier. So if all of you who are speakers, please turn on your cameras. I see that in the Q&A section of the system, we've already been answering some questions. So thank you very much. I'm glad that we've been answering some of these questions. And of course, I encourage our listeners to also continue asking questions if you feel that you'd like additional information or something isn't clear, or if you have another question to ask one of our speakers. So I think I'll start with you, Dr. Liu. You know, Singapore does have a strong national insurance program, and certainly there is quite a bit of government investment also in the healthcare system in Singapore. And some of what you said also suggests that there is a regulatory environment in place in Singapore that is a bit different from other countries. And so maybe first I just ask you if you can remark on how this regulatory environment facilitates or constrains the relationship between the private and public partnerships in Singapore.
Okay, I'll try my best to answer this. I think Dr. Lim can also chip in, because of he will be the expert in the public health area. For us, for the longest time, I think the relationship between the public and the private sector GPs is actually quite well divided, in the sense that the GPs they have always been looking after patients that are from the contract employment, or they may be looking at patients with just a simple cough and cold, high throughput kind of consultation, very little chronic diseases, a lot of employment screening, etc. That's because the way they operate is really for profit today, and the setup is quite simple, like what you were saying, just a single or two office rooms space. So they had to sort of generate their own revenue without much government's need. So we see this change tremendously, especially as I mentioned from SARS, whereby the government recognized that these GPs are sort of left alone and not knowing what to do when there is a pandemic reaching our shores. So by and by, and as well as the aging population, so the government recognized that we need to engage GPs more into taking on some of the load from the public sector polyclinics in, for example, looking after patients with chronic illnesses that we usually see in our polyclinics. So that's why they are coming up with a new funding model, as well as allowing patients to use their MediSave, the country's insurance scheme, to pay for some of the services in the GP setting. So that is an evolving pattern that we are seeing, and we are glad that the relationship is getting closer and closer. I think there's still some tricky issues that occur in our setting. For example, the cost of medications. In the public sector, because we have bulk purchase, so naturally the cost of medications is much affordable compared to a GP where the price may be higher. So there's still this tricky situation whereby the funding from the government to help the GP see some of these subsidized patients reach this situation as to whether these medications should be funded to the private GPs as well, because the GPs they buy this medicine from a separate group purchase, so the pricing will differ. So, and similarly for laboratory tests as well as X-rays. So these are some of the tricky things that we have not really resolved yet, but it's progressively coming. I'm not sure whether Iwei has other things to help to input.
Yeah, thank you. And actually, as Dr. Wei, you begin to respond to this, there is actually a question from an audience that I think I'd like you to just briefly comment on Dr. Liu's, add to what Dr. Liu has said, but also perhaps you can just briefly mention, earlier when you were speaking, you talked about, the hospital at home program and going to the home to provide care, and sort of a social innovation model that allows, care beyond the hospital walls in a time like this for COVID. There is a question actually in the Q&A box that asks, the question says, in Lebanon, hospital capacity is overreached. And I think that this is not only in Lebanon, we see it across the world. And so the question is, do you have any advice on community-based care through primary healthcare centers? If you can respond to that question, and also perhaps position it in a way that you can also tie in the work that you're doing in Singapore with the hospital at home program. Maybe that ties in. So Dr. Wei.
Yep, thank you. Thank you for the question. I think the hospital at home program is a good example of how the COVID situation became a trigger, just like telehealth. In Singapore, telehealth use, including the polyclinic that Dr. Liu leads, has increased by 20-30%. And many agencies are also working with organizations like Gustav's, right, where we want to move information and healthcare into the digital platform. So the hospital at home is a typical example where there's the academic hospital with a home hospital team working with a private GP group that provides support, especially after hours support as well. In addition to that, we're working with a medical technology firm to deploy vital sign remote monitoring, 24/7 vital sign remote monitoring, including incorporation of a mobile app to alert healthcare providers if the situation has changed for patients at home. So it's at least a three-party collaboration, in addition to additional funding from the government to evaluate and to scale this model. And so I think it's a good example where primary care can play a big role, especially when there's technology, when there's the academic institution, when the hospital are involved as well. As to how to better provide more community-based care, I would say that involving social enterprises, social ventures are crucial in providing care in the community, whether it's acute care, inpatient care, or regular care. I mean, when we visit these patients at home, it's very clear that even though we're treating an acute situation like pneumonia, but they need patient education as well. Someone has to teach the patient about reducing salt intake, because clearly heart failure was due to too much salt intake and fluid intake. But as the audience asked, the capacity is peaked, right? Healthcare providers are not just having to manage COVID patients, but other acute cases. So how do we engage community partners? And there are social enterprises in Singapore, like Jagami, which provides a Uber-like service where it matches nurses with patients in the neighborhood, providing basic nursing care and health education. So that's an example of an innovation that came from the ground up before COVID that has been deployed quite effectively to provide a basic non-acute community-based care, including patient education and preventive care. So yes, I hope that example illustrates how community-based care could be improved in a COVID situation.
Yes, absolutely, absolutely, it does, and maybe I can just move very briefly into picking up on what you said, Dr. Liu. Maybe I can ask you, Gustav, when earlier Dr. Liu mentioned incorporating medical technology and mobile platforms to applications in Singapore, which is what you've done in South Africa. So, and honestly, 8 million users, it's really incredible in such a short period of time. And the fact that you've also engaged the South African government and the Ministry of Health has endorsed it, I think these are really important factors. And I see, Dr. Liu saying similar things in Singapore. My question to you, Gustav, is how can you leverage this platform to provide broader support of UHC's efforts in South Africa, beyond even COVID and vaccine delivery or alerts on vaccine hesitancy, which is a big issue that we're going to be seeing in Africa soon. So what do you think the appetite of the South African government is to take this model, this technology, this platform, and sort of roll it out for other things like regular care, maternal health, etc.?
Yeah,
Gustav?
Yeah, I see Dan's comments. Let's take to the US. I think your comment there, that we're also astounded. I mean, 8 million users is pretty crazy from a cold start. But I think it shows how much pent-up demand there is for what Dr. Lim also mentioned, like non-acute care. So this idea that we can provide an intermediate level of care. I mean, so much of this, especially if we look, and then I think that points towards the type of services that we can roll out in these kind of, let's call them low touch or digital environments. NCDs. So, there's one organization that's using our platform now. So the way I'm thinking about this, the COVID-19 has become a forcing function. It kind of, I mean, having a human in every household in South Africa who is connecting with the central service is mind blowing. And so it means that we have a connection, and we could say, oh, use Health Connect. We could just say there, if you, and one of the organizations that's using our platform now is called Strong Minds. They are a non-profit, and I think what's interesting is that specifically around they focused on mental health in Africa specifically. And you know what? Until March, they'd never done anything digitally. The entire model was based on mental health care with a version of a community healthcare worker. But they had to go into villages, so it was basically a village health worker for mental health. But they've taken that model and they're now rolling it out onto this platform. And so I think what's really incredible is that for certain areas that we wouldn't even, if you think about psychiatry, psychology, mental health, a lot of areas that you would have zero care whatsoever in rural areas in Africa, you could now potentially at least have that starting function, so you could triage and then say, hang on, this person needs to get to a primary healthcare facility. So I think so the areas we're thinking about are those kind of underserved areas. So specifically mental health, non-communicable diseases, and then anything that's behaviorally driven, we think would be a candidate. So, experiments around, I mean, obviously vaccine hesitancy and combating fake news is important. But other elements as well. South Africa's got a diabetes explosion at the moment. So as we get out of COVID, are there behavioral programs that are evidence-based that we could potentially roll out onto this platform? Because we have, the most important thing is we have the attention. We have people checking in every day. That's a tremendous privilege to have when you have patients actually seeking care. And I think that's really what really this points out is that there's no way that our public health system could withstand 10 million patients going to primary healthcare facilities, but the fact that we can actually provide a secure mechanism to provide that first level of care is really the exciting bit. And then I think there are lots of things that we aren't even looking at yet that I'd love to see other organizations looking at this platform. So for instance, we're not doing sentiment analysis. We're not actually looking at the data. We're not yet even looking at and I think the big question is, which we haven't solved. We don't know yet whether accessing these services, we'll need to look back. And I think, as Dan also pointed out, we'll need to, in a year or two's time, we can look back at this year and kind of figure out what really actually happened, because we don't yet know what impact these digital systems have. How much are we alleviating pressure on our physical systems? And so there's still a lot of research to be done and to figure out. I think the positive for us is just that there is so much demand, and that we can roll this out in resource-limited environments.
Excellent. Thank you, Gustav. I'm looking forward to seeing how South Africa fares with this, because I know, for example, in Kenya, all the messaging goes through the Ministry of Health, and we have a set of messages. Even in Ethiopia, here where I'm taking this call from, a very similar thing, and it's really rewarding to see the kind of responses that you've received around there. I'm going to just move to Dan for a second, and then I'll come back to you, Gustav. Dan, you talked about this new approach of delivering COVID intervention in the US. And, even though you said earlier, we recognize that, you said governments can have strong leadership, but they may be incapacitated. And I can't necessarily say that might be the case in the US, but what I would like to ask you is, you've already adopted this model in, New Jersey, North Carolina, Florida, Ohio, of working directly with the community. First of all, the question I would have is, number one, do you see this model that you introduced being much more broadly adopted even beyond COVID, and certainly after COVID, if the clouds clear for the US? And then secondly, there's been some discussion about technology as a driver for, sort of innovative approaches, etc. Have you considered within the PIH model, the US Public Health Accompaniment Unit, have you considered the use of technology? And if so, what are your thoughts on that?
Sure. Well, so on the first question, I think that there's the model of the PIH intervention, which is really, just sort of technical assistance. And that's where, yes, we are planning to expand. I hope that we continue this for some years in a variety of different communities. But one of the things that has been sort of essential to our success is that it is, by virtue of being grant funded, it is also apolitical, and we are a very neutral intermediary that is able to break through some sticky coordination challenges between other partners that are sort of on the ground. So in that sense, yes, we do want to expand, but there are some, just sort of constraints generally about how we do that. But in terms of the model that we promote, and the model of really thinking through how social pathology intersects with medical pathology, and establishing these sort of cadres of what we're calling care coordinators, which is a certain sort of kind of community health worker that we've introduced now in a number of places for COVID, and whose sole job is to reach out to positive cases and exposed contacts and say, do you need food? Do you need home PPE? What else is it that you need? And we get some very sticky issues that come up. We get issues with migration and documentation. We get issues with domestic violence. But, that model of sort of walking hand in hand with someone the whole way through, and not just saying, okay, we got you to the testing site. Now, 7 days later, you're going to get a test result. It's too late for you to do anything with it. And even if you had gotten it on day one and you were positive, there was nothing you could have done anyway, because you live in this 7-person, 1-bedroom household, So that model, I hope, is something that becomes pervasive, because that has been, I think, the piece of the PIH sort of ethos that has been picked up the most in with respect to the partners that we're working with. And I do think that there is this reckoning that is happening in the US right now, where all of a sudden everybody is starting to say, wow, these neoliberal tendencies of completely destroying the social safety net over the course of the last number of years, that's not good. That leads to the situation that we're in right now. So that's the model question. On the technology question, yes, we do use technology in a number of different ways. There are lots of different softwares that are out there for maintaining these massively complex contact tracing databases. So we work with Salesforce in Massachusetts. We work with ComCare, which is a product of Dimagi in Navajo Nation and in Newark. And these tools are quite helpful in making sure that there are clear workflows when your workflow is insane, when you have 7,000 new cases a day in a place like Illinois, and that means 14,000 new contacts a day, and you need to reach out to all of those people. How do you do that? And we've over time grown to understand the various uses of these different platforms and how we can use text messages in advance and inbound call-in lines and all sorts of different things to generate higher sort of engagement in the community. I would say that we don't have anything in the US that is like what Gustav has cooked up in South Africa. And as I mentioned in the chat, that would be great. But I think that we're still a far way from any sort of nationalized response, certainly not before January 20th of next year. So we'll see what happens there. I think that hopefully answered your questions.
Yes, it does. Thank you so much, Dan. I want to just swivel over back now to Gustav on the issue of technology, use of technology platform. Just a quick one on, what are the partnership models that you've entertained, or have you not, with the various media houses? Because I do know that, signing on 8 million users is a big deal, and that must mean that you have some level of control over information and misinformation. So what is the partnership model with media, which is what people are listening to, looking at every day? And how has the model of partnership that you have with the Ministry of Health addressed partnership possibly potentially with the media houses in South Africa?
So I think I think the next couple of years are going to get there's some really big unsolved problems with let's call them these complex adaptive media. Well, let's call them social media to be frank. And in Twitter you can still see how information is spread and you can track it, but in WhatsApp you can't, because they privately share messages. I think one of the big things that we really worry about is these private groups. They are like Tinder. When you have memes, and unfortunately it's a side effect of the way our brains are constructed, that we just like sharing. We like sharing information that's scary, or that's explosive, and that's not necessarily true information. And I don't think we've got really good models for combating this. We're seeing some really early things that the fact checkers are doing. We're seeing some work that Twitter is doing and Facebook. But unfortunately, that's only possible when you have visibility. And so one of the big things that we haven't actually mentioned here at all is this idea of privacy. And so privacy is at the heart of health. You can't, the patient-doctor relationship needs to be private. But now so much of our health intervention is through these, people believe. Vaccine hesitation and anti-vaxxers, people believe the things that are shared with them on private media channels. And I don't think we have solutions for those things yet. As a matter of fact, I think it's going to get worse before it gets better. To the examples that I think Singapore is really interesting. If you take these two extremes, in the US, there's a lot of false information floating around, and we're not really doing a great job in stopping that. I think so. That's obviously a worry for us. I'm a fairly optimistic human being when it comes to technology, but I'm really worried about the effects of this the let's call it consumerization of health and the lack of control that we have there. I think the positive, I think to your question specifically around media, and a lot of the countries we operate in Africa, there is still some centralized control. And so the reason we could get to such scale in South Africa quickly is because there are still, I think that's actually the interesting thing. Before social media, you have a couple of channels, and if you control them, if you can get your message out on them, then you have broad distribution. I think the problem is when you get into a more fragmented media landscape you have in the US and now globally, and increasingly in the rest of Africa as well, that there's very little that you can do once these messages, you can't control the narrative anymore. And I think, I don't want to sound too negative. I think there are solutions. It's just, I think we're just very, very, very early in the day. I want to say one thing. I want to end on a positive note here, because I don't want to make everybody depressed about the bad social media. But the positive is that what we have been doing, we've been training some machine learning models on our national scale platforms. And so what is interesting is if you think about the best possible doctor, when somebody WhatsApps you or messages you, your doctor can kind of just pick up. There's a lot you can pick up very quickly, and we can train machine learning models to pick up a lot of those signals. And I think what's really exciting is that on these national platforms, these really large scale platforms, we can train models to give us signals, to pick up on these signals and give us early indications of when people are under stress or when they need to be triaged. And I think that's super exciting. And hopefully we can use some of those same techniques to combat misinformation and fake news as well.
Absolutely. Thank you, Gustav. I know there was a question from the audience about, how do you sort of, is there a legal framework to mitigate misinformation on COVID? And Dr. Liu said yes. In fact, the government put in a legal act to prevent anyone who sent wrong messages. So unless you have a government like Singapore, which puts out actually a law that says you can't misinform people, it's really hard to manage communication and information. There's also another question here. Gustav, I'm just going to ask you just to comment on it briefly before I move on to the next question for the next speaker. But the question here is really around youth and communicating with youth, risk communication for youth. How have you integrated that into the platform that you're currently using? If you can just share that with me briefly. And then I'm going to open that up actually to our other speakers as well, because, for example, in Africa, the majority are young people. And so what kind of effort are we making to address the information needs or the interventions of young people? I'll start with you, Gustav, and then I will come up to Dr. Wei and Dan. Maybe you can just respond to that as well. Actually, not Dr. Wei, I'm going to ask you to synthesize what you've heard, but Dr. Liu and Dan, I'll ask you to just follow after Gustav. Go ahead, Gustav.
I love the question. So we have we actually started working with youth. That's 12 years ago when we started doing work, we started with youth, and the reason was because we felt that the only way to communicate with them would be via their mobile phones, because they're constantly using those. So I think using social media channels, that's the one place where it makes it, the negative side of social media and this high virality and shareability of the content makes it a fascinating channel for communicating with youth. Obviously, I think I want to cite one example, which is not work that we've done, but it's a partner organization that's using that we're starting to work with now, which is called the Peer Health Exchange, and they've done sexual reproductive health work. And again, COVID has been a forcing function for them. They used to only train young students who went out into schools, primarily in the US, to do sexual health and reproductive health communication, which generally, that's always, nobody trusts the old guy or old person. But if you have a young person who does that, then it's very successful. And obviously they had to halt that because of COVID. So they've launched their program on TikTok, and it's been, you must see, there's not content this content is so crazy. But they have 30-second. There was one clip that I saw, is like the 5-star rating system on prophylactics, and they had over 1 million views in like 7 days on this content. And I think I'll share some of that in the chat as well. But I was super impressed. I think there are amazing channels to reach youth through these channels, and especially if you have something you speak in the language and the formats that they like. So yeah, I'm very excited to see what these groups are going to be doing.
I think from this end, in terms of the youth question, there's a couple of things that I would just sort of flag. I'm sorry, can you guys still see me? My internet is cutting out a little bit.
Yes, we can see you.
All right, great. Sorry about that. You know, what we found is that youth in the US are obviously very keyed into social media, as they are everywhere. There is also this sort of air of invulnerability where people aren't taking it as seriously, or younger people aren't taking it as seriously because their health outcomes are not going to be as poor. And so a lot of the messaging has been around, if this is not just about you, but it's about your family and your community and so on and so forth. It has to be so tailored to the sort of specific environment. But the two things that we have found that are really kind of effective are, one, a very, very targeted social media engagement. And in the places where we've done this best, we have hired an expert firm to work with like hyper local social media influencers. So not like who's the social media influencer in the US, but like who is the social media influencer in this particular zip code in Newark, New Jersey, and have those individuals sort of distribute the messages. And then I think that you cannot put a premium on this sort of good leadership question. And so the other thing that has really been able to reach youth places that we work, like Navajo or like Newark, is having the local political leaders engage in a meaningful way in person. I mean, socially distant, safe, etc. But the Newark mayor had started this sort of street team where every single day he was going out into the community and speaking with youth groups about how important this is and how to take it seriously. And that was the other thing where I think we saw a pretty significant change and change in behavior, I would say. So it has to be really sort of specific to the community, and it has to leverage both the sort of social piece and then, to the extent possible, like in-person local leadership and role modeling.
Thank you. Dr. Liu, I was going to ask you to speak on the same, if you can just touch on that very briefly, but also if you can talk to, there's a big data element in terms of the models that you work with in Singapore. Just if you can just briefly also answer the question about data. Who owns the data? Who manages the data? etc.
The question on the data, I'm afraid I can't see where is the. Are you referring to the one in the question and answer?
No, I'm just saying Singapore has a very robust system, a system that is connected. The government and the private sector has a partnership, and people are coming into the health system to get care. But you are you must have a very robust data system or network to sort of manage and understand the patients as they move in and out from the polyclinic to the government facility, etc. So just very briefly, I think it's data is such an important element of any type of system, a health system. Can you just briefly remark on the issue of data? How is it captured? Because I know it goes to the government at some point, and who's responsible for that data?
Well, most of the public sector data, they come into a common platform. We have a national electronic health records. So these are the, in a way, like legislated information that need to be housed there. And we can share information about the laboratory results, the medications, and then the inpatient discharge summary. This is, thus far we are able to do that. Our challenge is that we still have two big EMR systems in our public sector. Right now, my polyclinics actually started using Epic, and there's another cluster using the Allscript from both of them are from US. And for the private sector, it is a different picture. They have the different EMR systems, and which is not linked. So the government is doing what they can to persuade the private sector to share basic informations about the medications and the laboratory tests, so that the patients need not be paying for another set of tests if they go to another cluster of hospitals or polyclinics. So there's still some talks and negotiation. They have not legislated yet. So whereas even interestingly for our patients, they actually have a right not to put any of the information into the national health records. They have to sign a form to opt out from the system. So they have the right to the signature for this, and we will have to remove it entirely from the national records.
Thank you so much.
Maybe just like to just add something about the youth mental health. I'm not sure whether I may not have time, but just two points. Interestingly, for COVID, the youth are starting to support what the healthcare workers are doing. So they've been writing notes, bouquet, even write songs for us to thank us for the work. And the second situation is not so good. It's on the mental health issues that's on the rise. So it's something worrying. Yeah. Thank you.
Thank you. Thank you, Dr. Liu. We have exactly 1 minute or perhaps even less. But Dr. Wei, very quickly, if you can, what are the few keywords that you can, when in hearing what everyone here has said, any advice from you? Very short, 1 minute, less. Thank you.
I would say that we must not just plan for a reaction to what COVID has done to us and provide PPE, provide testing. And I think all the examples from Gustav to Dan to Dr. Liu show that there needs to be a long-term planning. And whatever we do now, we have to think about the post-COVID world, the post-pandemic world, whether it's about a digital platform that can move to NCD care, or whether the PIH model can address other issues within and without the United States border. So I think long-term planning for partnership and infrastructure beyond the pandemic is probably the most important long-term view that all of us would have. Not only because it helps us with the planning, but it also gives us a sense of optimism that we can really fight through this pandemic.
Absolutely. Thank you so much, Dr. Wei. I'm going to call Priya back. Priya, maybe you just close us out. Thank you to all of our speakers. Very interesting. And it has been my pleasure. Priya?
And I'd like to thank Dr. Yi-Jen Liu, Dan, Gwenelle, Gustav Prakelt, and Dr. Yi-Wai Lim for really an exciting conversation. I think if there's one thing that I'd like to take away from this is primary healthcare has been so underestimated during the unfolding of this pandemic. And I think so many governments, both in the global north as well as in the south, have underestimated and underinvested in primary care systems. What we have seen now is the role of innovation, integration, and amalgamation, as well as quick response in the front line that primary healthcare has provided, not only to address the direct elements of COVID, but actually takes it to a far more crucial level where it has to address a lot of the collateral damage that is being caused as a result of COVID-19 and the implications of this in future health systems design down the line. I think the discussions have actually begun a catalyst of sorts, I think, for much deeper levels of engagement, both in terms of research as well as practice. And I'd like to thank all the speakers again for your really deep and enriching insights in today's webinar. Thank you so much. And we really look forward to having you participate more in depth in our mutual learning platform as well as our series. To all those listening today, please do look out for our next sessions over the next couple of months. And thank you so much again. Thank you very much. Thanks, Desta.
Thank you.
Thanks.
Thank you.
Thanks a lot. Nice meeting all of you. Bye.
Thank you. Bye-bye.